Good morning, ladies and gentlemen. My name is Daniel, and I'll be your host and moderator for today. Please, to everyone at home and to everyone present in the auditorium today, please make yourself comfortable and enjoy the rest of the session. Now, a couple of ground rules before we start. For the audiences present here in the auditorium, please ensure that your mobile phones are on silent or turned off. For our audiences present online, please make sure that your microphone is muted throughout this event. There will be a Q&A segment after the dialogue session where audiences online and offline may present your questions to our guest panelists. Now, thank you all for joining us today in this event. I would like to take this opportunity to thank the Alumni Association and the Alumni Relations Office for organizing today's event. It was a great pleasure to have the chance to host this session with Yang Berbahagia Tan Sri Dato Dr. Abubakar Sulaiman and two of our fellow alumni, Dr. Paul Chan Hong Kit and Mr. Lim Kian Ping. All right, so let's begin today's event. To start off, we would like to invite our three guest panelists, Tan Sri Dato Dr. Abubakar Sulaiman, Dr. Paul Chan Hong Kit, and Mr. Lim Kian Ping up onto the stage and to have a seat. Now for everyone at home, the pretend round of applause. Everyone here. A round of applause for our guest speakers. Thank you. Firstly, introducing Yang Berbahagia Tan Sri Dato Dr. Abubakar Sulaiman. Dr. Abubakar Sulaiman attended Malay College, Kuala Kangsar, St. John's Institution, Kuala Lumpur, and Geelong Grammar School in Victoria, Australia, and obtained his MBBS from Monash University, also in Australia. He obtained the Masters of Medicine, Internal Medicine, from the University of Singapore. He became Fellow of the Royal Australasian College of Physicians and did his postgraduate training in nephrology at Georgetown University Hospital, Washington, D.C., USA, and Prince Henry's Hospital in Melbourne from 1975 to 1976. He's currently the President and Board of Governors for the National Kidney Foundation, the NKF, and the Chairman of the Medical Defence Malaysia. Dr. Abubakar Sulaiman was appointed Director General of Health Malaysia from 1991 to 2001, representing our country on the world stage on numerous occasions. He later assumed position as the President of International Medical University from 2001 to 2017 and was Chairman of IHH Healthcare from 2011 to 2017. He's currently the Chairman of International Medical University, IMU Group. Wow, am I right? Introducing our second guest panelist, who is our very own IMU alumni, Dr. Paul Chan Hong Kit. Dr. Paul, ME2/98, graduated from the IMU MBBS program in 2003 with distinction in his final semester. Dr. Paul also obtained his MBA in Healthcare Management in University Technology Malaysia, UTM, in 2013. Dr. Paul is a Certified Medical Impairment Assessor, CMIA. He's currently the co-founder and CEO of Sievert Imaging Center, which is the first radiology diagnostic center in Sandakan, providing radiological services such as the ultrasound scan, general X-ray, mammography, bone mineral density, and CT scan. He was previously the director of Little Craft Harbour and Eastgate Medical Clinic. He was the Chief Medical Officer and Medical Director for Doc Tours and the Deputy Director for Hospital of Kent, Sandakan. Dr. Paul was also the Principal Assistant Director in the Medical Practice Division for the Ministry of Health. Lastly, our final panelist, also an alumni of IMU, Mr. Lim Kian Ping. Mr. Lim, BP107, graduated from IMU's Bachelor of Pharmacy program in 2011. He's currently the CEO of Aipharma Healthcare, a pharmaceutical distributor that concentrates its business in the niche market, focusing on the sustainability of the pharmacy and pharmaceutical industry. He was previously the Chief Business Optimization Office and Head of Department at AMPM Pharmacy Malaysia. He is also a columnist who has previously worked with MPS, Young Pharmacist Chapter, and a columnist for the Chinese newspaper, answering questions and debunking myths related to health. Mr. Lim has also made multiple appearances in many different radio interviews. Good morning, gentlemen. Thank you for taking your time to be here today. It is an honor to be amongst influential figures in Malaysian healthcare. We hope that you will be able to share your knowledge and experiences from your respective fields to everyone here today, to our friends in the Zoom call and to everyone present in the auditorium. Now, our topic today is the future of healthcare and what awaits. Ooh. When we talk about the future of healthcare today, there's one topic that will always come to mind: the COVID-19 pandemic. It is a life-changing phenomenon that has affected everyone around the world, even up to today. Today's topic will be focusing on the healthcare industry before, during, and after the pandemic. We will also focus from a healthcare practitioner's perspective and what awaits us in the future. Okay, now I've seen it. Okay. Now we will get to the panel discussion, starting with the first question. Since the start of the pandemic, many industries were forced to make changes to adapt to the current situation. Please share your views on how these industries have managed to adapt based on your respective fields. Perhaps Tan Sri, you could start by sharing your views from a government's perspective and also from an educational institution standpoint.
Well, I think you all have experienced the pandemic, and you can see how the whole country and the whole health system was not really prepared for such a major outbreak. We never had such a major outbreak in the world, actually. If you compare it, I suppose the Spanish flu was some outbreak of that can compare to that. But in Malaysia, the outbreaks were more limited in terms of SARS and from our disease, Nipah, so they were contained. But for this one, the outbreak affects everybody, every state in the country. So you could see that the hospitals were not prepared, and the response by the government initially was good, but then after, remember, the Sabah election, things got out of hand because they did not follow the SOP. So you could see then there were difficulties in triaging patients. So this comes to number one, the locations where patients go to. So many of them were not ready with the SOP for triaging. And when they did it, it could have been better. So you see now how many people have suffered from this. Over 10% of the population have suffered from it. Okay? 7,000 deaths. 7,000 deaths. Out of 33,000 deaths, there were 12 dead. In other words, they did not know it. So why did this happen? So we need to investigate. So we were basically ill prepared. So we need to be very prepared. To me, that's one. But earlier than that, our ability to control outbreaks or communicable disease of this nature have to be a lot better than what it is now. I mean, we had previous outbreaks, but again, you can see the carnage that has happened, not in people and their livelihood and the economy, and we just have to spend enough money, not only on healthcare, but also on preventive care, early detection, and promotion. So, I'm definitely very probably government spend billions. But one major issue, I think, that is a problem around the world, and that is the trust issue. People cannot trust the government. They don't trust the doctors. They don't trust the scientists. Okay? So the anti-vax movement becomes so powerful. And then doctors, scientists, they do as well. So these are all issues that are very complex that have to be addressed. So can we be better prepared for this in future? So that's our question.
Good. Tan Sri, thank you. That was very insightful. Dr. Paul, how about your views coming from the private sector yourself? How did you cope and adapt to the changes?
Hello. I think was what Tan Sri mentioned earlier. The pandemic actually caught us by surprise. By surprise. I mean, as Malaysians, we have gone through a few waves of infectious disease pandemic previously, and it has not reached to this great extent as what COVID had caused us. Right in the not only in the public sector, I think in the private sector, we are ill prepared as well. We never thought that something like this will happen, that it will change the way we practice medicine and change the way we in fact run a healthcare facility. Not only in the healthcare setting, I mean in general setting, look at what we are today, right now. We are sitting so far away, despite the fact that, we have good friends around. We can't shake hands because of the pandemic. It has changed the way we live, right, on a day-to-day basis. So in the private sector, we were ill prepared, right? Ill prepared for such scales of pandemic. Not only in the triaging component as well, but as far as primary care as well, the doctors are unaware. This is something so new that we do not know what is hitting us. We ask ourselves, what sort of infection is this? What are we going to do? Is there a way that we can prevent ourselves from getting it? Things like that. You see, I work in Sandakan, which is a pretty small town. We have about 30 to 35 general practice clinics over there. There were one time in 2020 that all private clinics were closed. All private clinics were closed for one reason. All of us were scared to be infected. Of course, at that time, none of us got infected yet, right? But all of us were so worried about getting the infection. And what will we do if we were to get the infection? Are we going to close it down? Are we going to be admitted to? Will I be admitted to ICU? If I get the infection, those questions were in our mind. Patients ask us the same questions, and sometimes it's very difficult for us to explain to them at that point in time, because the truth is we do not know a lot of stuff. We have no data to show. We have no research to back us up. We could use information that given by WHO from our ministry at that time, and we were just we function like an intermediary where we collect the information from the MOH and then decipher them and then change it into a day-to-day language to educate our patients, right? But it was quite a tough period for most general practitioners. As you can be aware that lots of patients doesn't go to doctors anymore at the time. They would not want to step into a healthcare facility, even though they're sick, even though they need doctors or any healthcare services. They will not step into it because they are not worried about being hypertensive. They are not worried about getting cancer. They are worried about the moment I step into a healthcare facility, I will contract COVID. So it's something huge, something different. They shy away from healthcare facilities, especially in the general practice setting. So yeah, I mean, in sum up, it actually caught us by surprise. We were stunned. We were stunned to a huge degree. From a usual huge number of patients now become less than 5, less than 10, less than some even no patients a day. Sustainability came into issue. How are we going to pay our staff? Will this clinic go bankrupt because of this? A lot of things came to our mind during that time. So it was a very ill-prepared time for us.
Yeah, thank you, Dr. Paul, for sharing. From a pharmaceutical point of view, Mr. Lim, how has it been like in your industry, especially with the high demand of medication, of vaccines? how has it affected you?
From pharmaceutical point of view or pharmacy point of view, right? We can share some insight during these pandemics and also what are we lacking of, right? At the beginning of the pandemic, right? Everyone was so scared. I mean, including pharmacists are scared, right? Because community pharmacists are being excluded, being the first phase of people being healthcare professional being vaccinated, until our profession go and protest and then go and ask for help, and then only community pharmacy being included in the first phase of vaccination. That actually considered part of the things that quite surprised us in the beginning. But if you look at the overall pictures, we look into data, we realize that during pandemic in 2020, 2021, the medication used to treat non-COVID, I'm talking about like maybe hypertensive, diabetic, the overall data actually going down. So how can it happen? Meaning that is it that during COVID time people don't get hypertensive, or is it during COVID time people don't get diabetic? So it's not true, right? So there's a disconnection when this pandemic happened, right? Our government all healthcare facilities are so busy dealing with COVID, and they are not so emergency diseases, right, are being neglected. So people stop going to facilities, healthcare facilities. People stop going to see doctors. People stop taking medication. I have a lot of friends and family people around me that they don't refill their medication because they're scared to go to healthcare facilities as being shared by Dr. Pong. That is one thing that we observe. And luckily, something quickly kicks in is that we have telemedicine, right? Government giving a lot of support into telemedicine in Malaysia. Although we don't have an act to govern on this one, but at least government gives some leniency and gives a lot of support into telemedicine, so that there are still people that are able to consult doctor through online. And the second point that I would like to share is our country in general do not prepare well to face any crisis. Very sadly to say. Why I say so is that until today, majority of our PPE, our diagnostic tests, we are still heavily depends on overseas supply. And there are very little R&D or little support like pre-COVID time that being put into this industry. And when this pandemic really happened worldwide, every country is rushing to grab resources. So it makes Malaysia in a very bad situation that we don't have resources, right? In terms of like COVID test kit, in terms of face masks. I still remember initial phase of the pandemic, one box of face masks, the price high up more than 100 ringgit. But in fact, the cost might be less than 10 ringgit in a way. So this is a lesson that we need to learn. We don't have oxygen concentrator. We don't have the technology in Malaysia. But if we look at countries like Taiwan and Korea, they have emergency plan, right? In a way, the government already planned, maybe because of their experience in SARS or MERS, they already have planned in ahead that they have industry to prepare certain parts, right? And for example, oxygen concentrated, it needs 5 parts. So they have each parts being prepared by one industry. And during emergency, they just call this industry to mass produce, and they can produce oxygen concentrator in a very fast speed. Whereas Malaysia, we still depends on emergency supply from Germany, Korea, and China. So all this, it must be a lesson for us to face. I mean, COVID, it won't be the last threat that human being going to face, right? So it must be a lesson for us to face for future emergency, right?
Thank you so much for your answer, Mr. Lim, and to all our panelists. So I guess we all share the same point that our country, Malaysia, needs to be better prepared in the future for future pandemics, in terms of like more trust in the government, more trust in the system, and also to kind of be more equipped for the next pandemic, right? Thank you so much for your answers, Mr. Panelist, all the panelists. Now, our second question. It has become more apparent now that digitalization has become a key component of everyday life. What are the current digital trends in healthcare? Maybe we can start with Dr. Paul. Yeah, thank you.
Digital trend. Well, the pandemic is good in the sense that it forced us to digitize ourselves. Previously, patients call us to, to talk to us on the phone. Right now, patients finding ways to communicate with us through apps and through technology. I mean, which is a good thing. The fact that my Sejahtera came to the picture now taught all my patients, which are all the elderly. I see a lot of elderly patients who are not technology savvy. They are still using a non-smartphone pre-pandemic era. So we had another job. The GPs got another job, which is to teach our uncles and aunties and our paws how to use smartphones. And it's not easy to teach them because firstly they can't see because the phones are so small, right? So, but digitization has been, maybe we have been talking about digitization even before pre-pandemic time, not only during the pandemic time. But I look at digitization or telehealth in 4 or 5 broad perspective. First, it's ABCD. I like to remember them as ABCD. A is AI. Now, all of us talk about AI. Now, I run an imaging center. So we have AI technology to help us to run tools on mammogram, on our x-rays. Right? If you go to a place and shoot an x-ray, you have a report from something generated for you at the split of a second without the radiologist coming to the picture. So AI. B, some of us have heard about blockchain before. Now, blockchain is just a different way of data storage. Gone were the days where all your data are stored in one place, which is one server. Right? Now we store data in multiple nodes. Right? Thanks to cryptocurrency, the same methodology is being used for healthcare. We use blockchain technology to store our healthcare data. Of course, the next things after B will be C, cloud. We'll talk about cloud services. Now, we in our practices, especially newer generation of primary care doctors, right, we put our EMR in a system, whether the system is local or whether the system is in the cloud-based. All right. But of course, personally, I love cloud-based because right now, even before coming here, I can check on my patients' medical blood test results and send an email to them telling them that, look, your cholesterol is high, it's higher than usual, or your LDL is way above control. I need to taper off your statin medications. Here, one of my patients is in Sanakan. All right, so that's where there's a digitization has been there. We have been using technology to help us in our managing our patients and operational flow. A, B, C, D. D stands for data, database. Data is not about just information. This D stands for security of our data. Our information are being held everywhere. All right. Now information is the king. Right? Hash is no longer king. Info is king. So the moment you start keying your information into my Sejahtera, for example, right, you're telling the whole world how old you are, whether you have diabetes or hypertension, etc., and so on. You're telling the whole world your IC number. And in fact, I overheard the radio. It says that my Sejahtera is your certificate is now your next identity card, because the information stored there, in fact, is more than what information is being stored in your IC. If you notice that you have phone number on your My Sejahtera, I can call you without you knowing me who I am, right? Because your My Sejahtera ID is linked to your phone number. So security, where will we keep our data then? Where will our ministry keep our data? Security, cybersecurity is a big issue, not only in the healthcare setting, the industry in the banking industry as well. At this juncture, security, the next term is residency. Some of us will not want our data to be kept outside the country. We want our data to be kept in Malaysia. This is Malaysian population, Malaysian health data. So I want to keep my data in Malaysia. But we do not have the robust system to help us to store our data. So easily crack and hack and so on. And majority of our server, your email server, are not based in Malaysia. All right, if you use a lot of Google services, for example, Microsoft services, they are not in Malaysia. Your servers are not in Malaysia. The nearest server will be in Singapore. So whatever it is, your data is outside the country, whether you like it or not. It's not in Malaysia. So data security is a big thing. A, B, C, D, E. E stands for very nice exercise. Now all of us here got a wristband or smartwatch or not so smartwatch to monitor our steps, right? Now it has changed our life, whether we like it or not. But it's also helped us as practitioners to see the patient's information. Right, when the patients come to us, we have a few who are very tech savvy, right? Come to us, look, doctor, this is my heart rate, or this is my BP that I enter into the app all the time. This is my sugar level. We have a way to communicate devices into an app to tell us what's the patient's sugar level, even before the patient comes to us. So those days when I was a medical student, we will review patients once every 3 months, once every 6 months. Right now, we have information real time on our patients on this. But then again, it's still linked back to ABCD, data security, how is it changed, database, etc., and so on. So the future of healthcare service delivery is definitely using technology. And whether we like it or not, we will embrace that. We will have to use that. The patients will need to be taught. My uncle, uncle, I will have to teach them how to use the app so that they can get their own information, their own personal health record on their phone. No need to go to anywhere else. If I were to refer my patients to Tan Sri, for example, so Tan Sri can have a system for him to see how my patients have been doing for the past 2 years. Right now, we have to write summary. If the patient see me for 20 years, can you imagine me writing 20 years summary? Cannot, not possible. And if I write a buku text for Tan Sri, he also will not want to read. So, but the simple, important data, patient health record need to be stored, need to be kept by the patient themselves, not us. The information belongs to them. It does not belong to us. So that's a gist of it.
Thank you so much, Dr. Paul. Yeah, I totally agree. Data is king nowadays, right? And yeah, so as you can see, like the technology has truly changed the way the medical industry as well. Cool. Thank you so much for sharing. Mr. Lim, would you like to share from your perspective?
Because talking about digitalization of technology in pharmaceutical, I would say COVID accelerate the acceptance of technology, right? Changes are there, right? Even pre-COVID time, we're talking about IoT, we are talking about apps. The changes already happened. It's just that COVID, this pandemic, accelerate the acceptance towards it. So one of the good example is just how I mentioned about the telemedicine, right? So moving forward, I'm expecting like more people can accept the use of IoT in managing the health, the diseases. So for example, previously, I remember one of my friends trying to introduce a technology into managing diabetics. So what they want the patient to use is to update, to upload the diabetic and the blood pressure data to the cloud so that they can collect enough information on the management of the diabetics and hypertension in the primary care. And that service is giving up free. But you'll be surprised that no people actually upload. Even though the devices are given free, they even incentivize the patient. If you bring back the devices, I help you to upload and I pay you 5 ringgit, and you will be surprised that actually very few percentage of people willing to do so. So I think it's the acceptance of using IoT in management of disease, right? But I foresee after this pandemic, the acceptance level will increase tremendously, right? It's just about the timing sometimes. So talking about digitalization of technology in pharmaceutical, maybe I can split it into 3 areas. One is on drug discovery. One of the questions that during my interview in radio station is people ask me, hey, how the scientists come up with drugs and vaccines so fast? I thought that we need more than 10 years in drug discovery, which is true. During my university time, I remember running a computer, we call it QSA, in a lab downstairs, running the activity, structural activity relationship modeling. So it's running, I will be sitting there and then I need to wait like maybe for 2 weeks to have one activity being detected. And that is only detected, right? But now the technology is being augmented with AI, machine learning, Watson by IBM. This machine is the artificial intelligence. They learn way faster than what human can do. So a QSA augmented by AI speed up the speed more than 10 times, right? And they can predict, right? Previously, we need to do a double-blind study to test the toxicology of a molecule. And now they can use AI to even predict it. So that actually fastened the drug discovery process, right? And the second area that maybe we look into it is sales and marketing. So I'm in the pharma industry. During this pandemic, one of the very challenging part for us is doctor don't want to see us, right? Hospital don't want to see us. Hospital don't allow our sales representative to go in. So, and we have to adapt to it. Information still have to flow to the doctors, right? So it comes to, we are using like virtual sales rep right now. There are companies that come up with ideas of how to use data to driven our sales approach, right? So it's a data-driven approach. Traditionally, our sales rep need to knock every clinic's door to introduce our product. And now we're using data to tell us that we profile the GP, right? This GP is prone to, right? Maybe 70% is cardio cases, 20% is diabetic cases, things like that. And we profile the doctor even before we see them. So when we go and see the doctor, we already have a lot of information on our hand. And all these are data driven, right? So sales and marketing change our way to actually market the products into the industry, right? And the third one, we talk about digitalization and technology in our industry is personalized medicine, right? And we talk about personalized medicine, there are a lot of different types of precision medicine, personalized medicine. But I try to give a very layman example is that putting aside like cancer, chemotherapy, probiotics, right? We are talking about people have the impression that probiotics help in gastrointestinal symptoms. But is that really so? Is that like every probiotic, one probiotic suit everyone? So it is not true, right? So one of the project that ongoing is that we work with a company that doing microbiome genotyping, right? So basically we take the feces and then we do a microbiome genotyping and we tell that we correlate using big data to correlate back to the possible disease or possible symptoms that is caused by lacking of certain species of probiotic. And we supplement with certain probiotics into the patient. So moving forward, I am expecting more and more personalized kind of approach, including treatments of hypertension, treatment of diabetic. You will have major changes when we have this personalized medicine kicks in. Right, thank you.
Thank you, Mr. Lim. Wow, personalized medicine. So every patient has different needs. Cool. Tan Sri, you have many years in the medical industry. Perhaps what difference have you seen from maybe 30 years ago to today? What are the major differences that you see in the digital trends of healthcare?
Well, we're talking about digitization. It's happening very, very quickly. I knew we started the Masters of Health Informatics and we started Bachelors of Digital Health. And I think we are the first to do it in the country, but that has been started in other countries sometime. Okay. The issue now is that, as mentioned, this pandemic have accelerated the use of technology. And because you got to think about it, how we're going to use it, let's say, for the future, and how we have failed to use it right now. If you look at it broadly now, why do I visit the doctor? For example, you think about it. You see the doctor because you have a problem, maybe. And you see the doctor because you want them to look at your problem, evaluate it, and then discuss with you about the potential plan for the management of your health or your illness. And hopefully, it can be personalized, or better still, customized exactly to you That's the person. For example, we're taught the indication for this illness, for this, operation, procedure, or medicine. These are the indication. These are contraindication. And now, no, you can customize it to the individual because of the health data of the individual and the capability of, let's say, the equipment, the medicine that you're using, and the track record of the person or the hospital delivering the service. So you can actually project what will happen to you when you do this procedure, you get this treatment. This is the power of data. I mean, you're going to the predictive mode. Is this new? No. If you look at Malaysia's telehealth blueprint from 1997, this is what we're talking about. It's all there. For all of you that have not looked up the telehealth blueprint, please do. Even though at that time, the tools were not available because we created tools. You see it very slow. So what I'm trying to say, conceptually, it's not new. But to implement it, it is new. And the pandemic is going to accelerate the process. So if I were to look now, in the future, the role of the hospital will change. You don't want to commit to the hospital, or even go to a hospital unless you have to. And when you have to, you stay the minimum time. Okay? When you turn up an operation, everything can be done for me to prepare for it before. I just go for the operation, and most of the time, I'll go home that evening, or at the most, I stay home 2 nights at the most. Then I go home, and then I have to see the doctor in the hospital anyway. Can see him on telemedicine, on the computer, because the data will be streaming in. You got all the wearable, whatever you want to do. Okay? This is what we call remote monitoring. You see, his fitness trackers, his blood pressure, ECG, the ECG to monitor the person now is very, very sophisticated. Just from online ECG. So the technology is coming very fast, but its application in an integrated manner is not there yet. Okay. So what I'm saying now, I'm going to change the use of the hospital, use of the clinic. There's going to be more remote monitoring, remote care, and more care will be conducted at home. So you want to send the nurse to go to see the patient at home. If he has to remove the stitches, send the nurse. Okay. The doctor want to check on the patient the day after surgery, twice a day. Go through on the computer. It's not a problem. Now, what is the big deal? In the 1970s and 1980s, I was managing over 400 patients on self-dialysis at home or in the offices. In the 1970s and 80s, we trained them very well to do it without the use of staff. And dialysis is very complex. 300 mils of blood per minute is flowing through. You have a rupture, you can lose a lot of blood. But we can make it really safe. The patient can do everything. They prepare a machine, they can clean up, record the chart, and we monitor them on the phone. The first patient that went home on home dialysis was from Sievert. The second one was in Kota Kinabalu. How challenging is that? For example, 200 of them. Of course, CAPD, they're all over the place. And then you can dialysis. For example, CAPD, to show you how complex and how capable patients can be. Right? The patient may not say, oh, my fluid outflow in the dialysis looks a bit dirty. So we got a call center. We got a call center for hemodialysis, call center for CPD, call center for transplantation. I'm talking 1970s and 80s. No digital technology is on the phone. So we tell the patient now, okay, do you remember where you put the antibiotics? Do you remember how we taught you about sterile technique? So we talked through them, for them to draw down the antibiotic through sterile technique, inject it into the tube, into the peritoneal cavity. Okay, and then connect it up again, and to send the bag with the dialysis to us for culture and sensitivity. And then we say, okay, you can come here tomorrow because you're in KL. You're in Cebu or Tawau. See whether you can come tomorrow or the after, depending on. So what can you say? This is quite complex, but this is home care. This is remote care. Now, with modern technology, with digital health, digital medicine, it is so much better. It's so much easier. So we can manage patient 24/7. Diabetics can be monitored, not 4 times a year, or months. They can be monitored every day. And then the feedback we give to the patient, depending on the data coming back, can be automated. So yeah, whether they're meeting the targets according to the plan. So, but the thing is this now. Are the doctors interested to do this or not? Will they be incentivized to do this? Can doctors work together in a team? Okay. Some groups, doctors work in a team, but private hospital, they tend to work solo, which is not a good thing. In future, the most effective will be, even now actually, will be people working in a team. But the question is, what is the team? Different doctors with different specialties, nurses, highly trained for a specific job, pharmacists, whose pharmacy practice subspecialty area can support the activity. And then we will have specialized people to do data analytics, to deal with data security, not only security both to ensure integrity of the data, security that it doesn't leak out. So the concept of team then becomes much broader than what it is now. But it has to be. It has to be. So I think the transformation that has to come will be accelerated by this digital transformation. And it is inevitable. The question becomes how fast will it go, depending on the incentive system. The other thing is that what people benefit. The transformation must provide value-added services to the patient, family, and the community. The incentive must still be in place for the doctors, nurses, and everyone. But the beauty of it is that the potential to cut down costs related to improve health outcomes would be there. So this is our challenge. Can we take the leadership role? And do. And I think it's something that we would have to deal with. We have to work on.
Thank you, Tan Sri, for your input. I found it very, very interesting that even back in the 70s and 80s, that these concepts, these ideas were already there. It's just like the technology is just trying to catch up, right? And like, wow, to handle 400 patients plus from home doing their own self-care in the 70s. Wow, amazing. Cool. So it only can get more advanced, only can get better. Patients can take care of themselves more on their own as time progresses, right? Thank you so much for everyone's input. Now for our next question, this is what are the current challenges of the Malaysian healthcare system and what are the opportunities for improvement? Maybe we can start with Mr. Lim. I'd like to ask what are your thoughts from a consumer's perspective or pharmaceutical perspective?
If you're looking at challenges, I would say, if you're looking at private healthcare, I would say the cost is one of the big challenge that we are looking at. Private insurance, the premium is like climbing out. I think this year they just review all the premium that we are looking at. When we look at the whole industry, right? I think if we boil down to the roots, the cost optimization is the one that we need to look into it, right? So whether the resources that is overwhelming or whether we are still lacking of resources. One of the very interesting study that I've seen is that in Klang Valley, the number of MRI machine that we have in Klang Valley is more than the whole Australia, right? So I mean, this my paper is written, is published on internet. You can go and read about it. But having to say so is that every private hospital maybe will have their own MRI machine, and every patient that come in, maybe, some friends tell me that they might have some KPI, you know, how many patients that they need to do to take back the ROI, and this is the ugly truth, and that actually charged back to the insurance, and that will incur back to the patient. So I think cost is one of the challenges that we need to look into it. And on the other hand, government is paying a lot of money to support the so-called almost free healthcare that we are looking at. So this is actually not so healthy types of hybrid system that we are having, right? If you're looking at other country, they also having a hybrid version, but the gap is not that huge, right? Meaning that the minimum amount that every citizens have to pay is still there, or they can cover with a national health policies. That is another topic that we're looking at. So I think cost is one of the challenges, and the second challenges that I see is that we do not have a universal EMR information, right? To be used by everyone, to be accessed by all the healthcare professionals. For example, one hospital would want to keep their own IMR, and this hospital want to keep their own EMR. So the patients, when we go to this hospital, right, they want to take out the medical record to other hospital, they will face the challenges. And this patient, when come to community pharmacy, right, we can't access the medical record, right? So this is a big issue that we have to go and address it, right? There are several efforts being done by government or private sector that they want to have a universal EMR, but that actually does not come to a result yet at the moment. So if you ask me, in the future, if we have a universal EMR that can be accessed by all the healthcare professionals, it would be great.
Thank you so much, Mr. Lim, for sharing. Perhaps Dr. Paul, can I have your input on this topic? Yeah. Challenges of the
right?
Yeah.
I mean, in my opinion, right, the MOH is playing too many roles. The MOH are the provider, they are the payer, they are the regulator, they are the enforcer, policy maker, everything. Right? If we have one body doing too many things together, they will be bound to have policies mix will be skewed. All right. Let's just cite an example. Let's say I run an insurance company. I'm the payer, and I also run a hospital. On top of that, I also own a pharmaceutical chain. Now, what will happen if the patient goes to that particular hospital and the patient is under my insurance company? Automatically, things will be, doctors there say, oh, you are limited. You can only charge this amount to your patient. If your patient is you've got disease A, you can only use generics. And this is the cheapest generic you can ever find. This is the only one that you can use. And when you buy generics, you must buy from this pharmacy because this is my pharmacy as well. So this whole environment, this whole concept is like what MOH is currently doing. MOH is playing multiple roles, too many roles together, and to an extent where there are no focus. MOH do not have the ability to manage all together at the same time. All right, we need to separate them. We need to have a different imagine if I'm the insurance company, I'm also the enforcer and the regulator. So I come to your place and say, oh no, you cannot be my panel, or you have to penalize because it doesn't comply with the law. It doesn't make sense because you have one body being so many at the same time. I mean, I think we need to segregate it. We need to different parts of different value, different purposes have different body, rather than just one body doing everything together. I think this is a huge challenge which tied towards provider payer mechanism, right? And it's limited, funding is limited. Our MOH is being funded mainly from our general taxation, right? So the amount of money that's being given into the MOH to fund policies and fund, say, healthcare service deliveries are very, very little, very, very little. So we know that money is not being spent adequately, all right, to promote healthcare. I also echo what Tan Sri mentioned earlier about hospitals. Now, in the future, hospitals could be made irrelevant. Right? Could be made irrelevant. It is building hospitals are so expensive. Capitals are so expensive, and the idea of hospitals is actually tertiary care, which means that if I'm so unwell, I need specialized procedures or surgery or ICU care, specialized care, and then I want to go to a hospital. But right now, you are going to a hospital to do what? Blood taking, ECG, general consultation, health screening program. Now, these things can be done at the primary care setting. Why I want to increase cost at the tertiary level? Why the patient must go to a hospital to do health screening but cannot do at the primary care level? If you want to, if the person wants to check your BP, for example, go to a community pharmacy. BP checking is free. You can do, and not only that, they give you not only medication advice, they can give you nutritional advice as well. Isn't that much better than a hospital care setting? All right. If a person will do stress test, I recently had a stress test. Right, I go to a clinic, a specialist clinic, right, to do a stress test. I don't need to go to a hospital for a stress test. Otherwise, cost will be significantly increased. There will be a lot of unforeseen costs. All right, we can't blame private hospital for that matter because they have lots of space that are not generating income. Right, those business centers, income generating centers, are with the doctors and pharmacy, emergency services, etc., and so on. So they want to put as much people into this business generating income centers, otherwise they can't break even and things like that. Cost is an issue, definitely. But why have the hospital in the first place? Why do we have that? A lot of services can be done in daycare setting, ambulatory care setting, dialysis, for example. If the person is on CAPD at home, if the person is on HD, you don't need to go to hospital for HD. You can go to ambulatory care services for HD. If you need physiotherapy or rehab, you don't need to go to a hospital for rehab. You can go to rehabilitation center, ACC with speech therapists, occupational therapists in a very primary care setting level. In fact, there are lots of community pharmacists right now who are doing not only gone are the days pharmacies are just giving medication, right? Gone are the days pharmacies are no longer giving medication. They have so much more to provide. But community pharmacies have got so much more to provide. And community pharmacies are everywhere. Right? You can walk into one row of shop lots, they have 3, 4. Of course, now GP clinics also everywhere, right? So you can go to one row, you can have 3 GP clinics and 2 community pharmacies at the same time. So healthcare can be received from this touch point. No need to go to hospital, right? So, but back to the systems, policies, right? I think MOH is just playing too many things, too many roles at the same time. We need to remove some so that some of that can be given to a person that is a real passion for that. Digital health, for example, it has been there since 97. And Tan Sri was there. The digital blueprint is written by Tan Sri, by the way, right? The Telehealth Act 1997 was also developed during Tan Sri's time. I have the act. We read through the act, and it's still much very usable right now. It's 30, 20 years already, because the concept and the tools remains the same. Those days we use phone. Now we just use something else apart from phone, right? But the concept all remains the same, right? So if one person can pay focus 100% attention on digitization in healthcare services, right now I very much believe so that Malaysia will be the top digital health provider. All right, but that isn't such. I cannot recall if there is after some years, I can't recall if there's a unit tele kesihatan. Those days, yes, we have a unit tele kesihatan. I'm not too sure now there's still unit tele kesihatan in the Ministry of Health. Maybe there is a unit over there with 3 or 4 people running the whole show for the country. It may just not possible. It's not possible.
Thank you, Dr. Paul, for sharing. Yeah. Okay. Wow. So an international EMR system, that would be cool. Mr. Lim mentioned, and also the MOH should kind of segregate into different bodies so they can be managed better, right? Yeah, okay. Thank you for sharing, Dr. Paul and Mr. Lim. Now for our 5th question. This goes to Tan Sri. Since the pandemic, now the public has been more aware about the importance of healthcare services and also the importance of healthcare workers. Are there efforts, perhaps from the government point of view, being done to future-proof the careers of healthcare practitioners?
Before I address your question,
Yeah.
can I comment on the issue of the electronic medical record? Can I just hark back again to the telehealth blueprint? There were 4 pilots: lifetime health record, lifetime health plan, mass customized, personalized health information and education. The second pilot. The third pilot is teleconsultation, what we call telemedicine. And the last one was continuing professional development or continuing medical education. So if you look at the nature of the industry, to have an electronic health record, electronic medical record, is acceptable to all, it's not possible, because the industry want to keep and compete with each other. So they make sure it is not interoperable. Okay? Yes, they are willing to collaborate with certain partners where they can integrate. But by and large, it's very difficult. We discuss all that when we developed the development. So that is why we came up with the first pilot. Lifetime health record, lifetime health plan. So the lifetime health record sits above electronic health record. So we must have a set, the data sets. It can be on the phone or anywhere. That must be given to the patient after each transaction with the doctor. So in other words, what did the patient come for? What was done to the patient? What intervention was done? What is the health plan? What medication the patient's on? There's a summary. And when we worked it out, that summary will work maybe 95% of the time without referring to the original electronic health record. So that's the first one. The second component for the future is that we want to empower the patient, the individual, the family. We want to democratize medicine and healthcare. Now the doctors think that they are the center of the world. That's the way they behave. That's the way they organize themselves for their convenience, not for the convenience of the patient or the family. So that's got to be changed. When we go to all this, the patient and family is the center of the universe. The role of the health professional will have to change. We become partners, advisors, advocate, promoters for the patient and the family. It requires a complete paradigm change on the part of doctors and the professionals, and the way they're trained. So, to my mind, I'll just give you some example. This is from 23 years ago, 24 years ago. It's still relevant now. Now, you're asking me about, so there's a lot we can talk about, but for today, I just want to address that other issue, whether the patient can decide on everything because they're empowered, because mass customized, personalized health education and information, we must develop the tools for the patient to access information, education, data, and the tools to help them in decision making. And nowadays, with artificial intelligence, they can give all the evidence. And with personalized, customized approach, it can be customized for that person specifically. Now, in terms of future proofing professionals, you got to look at the change that's going to happen. If you look at the pandemic, what has happened? In the United States and here, they were overworked. The hospitals cannot cope. The other centers treating the patient cannot cope. The staff cannot go home. They stay in the hospital. Extended hours that they have to work. And on top of that, they have to deal with difficult patients, difficult family members who are naturally anxious. It's very, very hard on them. It's very, very traumatic. And on top of that, they got these anti-vaxxers who are denying the COVID pandemic and so forth, which destroys the morale of the health professionals. Working so hard to try to help people. They do what they do. Whether it is in Malaysia, US, everywhere. It's amazing. But what we find now, problems with mental health, problems with disillusionment. So recent data in February this year, coming from the US, my goodness, close to 70% of the nurses right now think. And I think something like 50% to 60% of doctors are thinking maybe they should leave. This is survey is done in February, right now, but they're still in the. So the question becomes now, how do we support them? This is not a Malaysian problem. It is a global problem. But to think it through. Because actually, what the pandemic has shown is very short of health staff, doctors, nurses. So we got to come to terms with it. In Malaysia, of course, not enough posts, the distribution of doctors. Like, he's a good guy. He's willing to work in Sandakan. That's what you want to work in KL, or in Johor Bahru, or Penang. You throw a stone, you got 30 doctors along the way. Whereas in the less developed areas, so the distribution issue, the long-term issue is a major problem. So if you want to think about future proofing, you got to study all this stuff. Look at where the need is. What would be the duties of health professionals? Look, all the students entering medicine in 2022, they graduate 5 years later. 50% of what they have learned will become less relevant to them when they graduate, because things are developing just so fast. So you got to continue to learn all the time. So the teaching approach, so forth, must enable them to be able to do that. So in a way you think it's scary, but no. We have to change, to adapt, to prepare our graduates for that type of challenge. And we can do it. So then, what then will be the future role? We got to think that through. So when we talk about future proofing it, how are we going to build, they say, the healthcare capability, capacity? How are we going to develop the supporting care that can deliver services at home? Chronic diseases need not be managed in hospital or even in the clinic. They can stream the data to the doctor. They can go and for the blood test if you need to. They might even be able to take it themselves and post it to the lab. The lab can send the result to them and to the. For example, those are the type of capability that going to come. So the question becomes, when is it safe to do telemedicine? In Malaysia, actually there is a telemedicine act. Malaysia is the only country in the world with a telemedicine act. But we have not actually enforced it because it's quite difficult to do that. You know? But in Malaysia, I'm sure the medical council will say, you must first do a complete physical examination of the patient in person. Once you know about the patient, then it is safer for you to manage the care over the computer. So can you see now? We have to look at the role. For example, patient with chronic disease, even urgent care, emergency care, triaging can be done on the phone. We discussed this when we did the blueprint in 1997. So if you look at this pandemic, there were weaknesses in our triaging system. Obviously, that's why the dropping dead percentage is so high. Imagine 1 in 5 got dead. 33,000 deaths, over 7,000 got in dead. So what happened to our triaging system? So in other words now, our capability and expertise, we have to change. You can do triaging on the phone. So for example, we discussed, I remember, a mother rings up at 2 in the morning because the baby is having diarrhea. Well, you can advise the mother on the phone first and then decide, should you come with the baby now or should you come at 8 o'clock in the morning? In the meantime, what do you do? And when you come in the morning, the A&E is ready to receive them because they're prepared. They know what has been done, who the person is, accelerate. So that type of capability can be done. Now, when we talk about care at home in the US, in the healthcare provider, among the leaders, 1 in 5 of them are already provided. So like in Malaysia now, to provide the care at home for patients with chronic disease, patients with, let's say, under hospice care, patients who are bedridden, stroke, we can manage them. We can send people at home, but we must mobilize the support services to be able to do that effectively. In other words, the whole transformation of the healthcare delivery system has to take all this.
Thank you so much, Nasri, for your input and sharing. Now it is 12:15 p.m. We will move on to the Q&A session. So I believe this is all the time that we have for the dialogue. Please, everyone at home and everyone here, please give a round of applause to for our panelists today. Now I would like to invite our panelists to remain seated as we would like to move on to our next segment, the Q&A session. Now the floor is open for any questions for our panelists, for all our audiences in the crowd, and all our friends in the Zoom. the floor is open. So for everyone in the crowd, we have microphones along the aisle, as you can see. All you have to do is raise your hands or walk towards the microphone, and please feel free to ask panelists any questions. Everyone at home, everyone in the Zoom call, you may use the hand gesture function, and we'll signal to you. You may introduce yourself, followed by your question. If you would prefer, you may also type out the questions in the chat, and we'll help you read it from there. Okay, let's begin the Q&A session.
Hi, good morning. Good morning, Tan Sri, Dr. Paul, and Mr. Lim. I'm Richard. I'm junior MO, currently in MOH Sungai Buloh Hospital. So the topic of future of healthcare is really insightful, especially to junior doctors like us. So I actually have two questions. I'll start with the first one first. Currently, there are like more than 30 to 40 private medical schools, and we produce more than 5,000 medical doctors a year. So with the future advancement of technology, AI comes in, one doctor basically can manage more patients compared to currently. Now, one ward, I need 3 to 4 MOs to handle the ward because patient can be quite ill. But with future advancements, patient diabetes, hypertension get more well controlled. We see less emergency DKAs. So we need less doctors in the wards. So how is it? Is it better? Okay, so how is do I need to repeat myself? Okay, okay, so how is it like junior doctors now in next 20, 30 years that you guys with very experienced view of it, and how the future medical universities will address issues like this? Tan Sri, you can give your input.
You know, you look at it in principle, the universities are always 5 or 6 years behind, let's say, the practice of the industry. Okay. In other words, as the industry changes, then the university then try to catch up. It's very difficult for, let's say, the university try to be current with what they're doing, because they have to prepare them for the practice in the community. So they should now become, you say, you got to envisage them. What will be the changes in the hospital, or the clinics, and what you're interested in the junior doctors, right? Basically, if you look at it now, all the experience of the junior doctors should be taken into account for their postgraduate training. And all doctors, before they go into independent practice, should be so certified to be able to work independently, whether it is in primary care, whether it is in hospital care, or whether in subspecialty. Because I think in the future, and it is already happening now, in the specialties and subspecialties, you already have hospitalists in this specialty. In other words, the people in this specialties work in the hospital, and others in the same specialty that work outside the hospital. In the US, that's already there. And even in Malaysia, I'm sure there's already there. So the work varies a little bit because the ones in the hospital will be the one requiring intensive monitoring and that type of thing. So we can foresee then when in the future, the hospital will only focus on patients that need, let's say, complex care and continuous monitoring and have to undergo complex procedures. So the training of young doctors then will take that into account. In other words, they should be working, you should be doing your housemanship in the health center and the community, as well as in the hospital, for example. So the training right now for the postgraduate work had to be completely revamped. It got to be reviewed. then we got to look at it in detail. But you see, if we look at there is so much technology going forward in the future, how do patients and doctors interact? Because the complaint is that when I see a doctor, okay, he sees me for 7 minutes, and he spends 6 minutes looking at the computer, and 1 minute talking to me and looking in the eye. How do you develop empathy in that 1 minute when you look at the patient's face and the patient's eye? Well, that is a practical problem. So we need to do research. For example, the electronic health record is not meant for healthcare. It's meant for administration. It is completely stupid for healthcare. So how do we revamp it to make it easier for the doctors and the nurses to use the electronic health record in a more intelligent way? The system must be more intelligent, so that actually the time that you have to spend 7 minutes with the patient, 6 minutes is with the patient, and 1 minute is with the electronic record. Because the what they call it is now intelligent. The artificial intelligence will drive the intelligence. So that part will have to come. So how do we then learn to develop empathy? How do we get the social intelligence part through the computer as well as face-to-face? That is something that we got to think through, and we got to develop, and we got to train. Because this fourth industrial revolution is relentless. Doctors will be dragged screaming into the new age because they don't want to change. So that is a major challenge. So when you say now about the work of the young doctor, senior doctor, they're not going to be changed. They have to be reviewed, got to be prepared physically for their role in the future.
Hello. If I could add on that, I think one of my concerns made earlier was that with technology and then now we have a certain amount of doctors in the ward, the workload now it's part of it being taken care by technology. How would you guys stand, right? I think that was one of the concerns.
And do we still need so much doctors actually?
Yeah. So I think we need to remember there's one thing that technology don't have that we have: the human touch. The human touch will not disappear as long as your clients, I don't call them patients because they're paying me, clients are human, they need human touch. Technology will allow us to streamline, to make our processes faster, quicker. When you want to trace results, for example, you can trace results from your phone so that you can spend more time interacting with our patients rather than spending more time running to the lab and things like that. So there's no worry about doctors not having jobs in the future with technology. No. Doctors right now, even in the medical schools, are being trained how to utilize telehealth to empower them to make better decisions, clinical or non-clinical decisions. Now remember, in health service delivery, it is not only hospital. Majority of the health service delivery are outside the hospital. All right. So let's say now you have more free time in the ward because technology has helped you a lot. Then use your free time to get out of the hospital, manage patients who are now not in the hospital, but they are already being monitored at home, home-based care. We want care to be delivered at home. So you can retrain and redirect human resources to somewhere else, to something that is matter more, which is spending more time with our clients. Right? I think that's what they want. If I go to see a particular doctor and I only spend 2 minutes with the doctor after waiting 2 hours, right, my blood pressure will go up lah. All right. Even if I normal BP, now I sit down very normal BP. After 2 hours, my BP go up. Then doctor say, "Oh yeah, your BP is so high. Check BP 1 time straight away, increase my medication." So, but the doctor only saw me only once for the last time he saw me was 6 months ago. You know, so with that transactional period of time, only one time only you see with 1 minute, it doesn't work anymore lah. It doesn't work anymore. We have to move we really have to spend more time to for our patients, for those who come to see us. They may have other problems, you know, may not be medical problems. They come to see us because my son cannot get into university, or my son do not know whether medicine is a good course for them to go, or my daughter want to join other Taylor's University, but I want to ask them whether IMU is better or not. So these are the information. No, they want this information. All right. Now in the small little place that I practice, right, patients come to see us not only for medical conditions anymore. They will ask for their children's future career advice. You know, that's where community-based practice is, because now you start knowing not only the patient, you know the whole family, and the family knows you. Right, rather than just very transactional, right? So do not worry that technology will supersede you. No, technology will not supersede us. Don't. It's not. Maybe it won't be in my lifetime, where you know, technology cyborg will come and take over you and then kill you and things like that. No, I do not know. Maybe in my children's future, in my opinion and personal view, technology will not overtake us, but it will help us a lot in our operations, managing our clients, etc. So don't worry, you still have a job.
One last one. Just now we talked about lifetime health record at EMRs. I'm totally into this, and because we also have faced difficulties. Just now, Tan Sri also mentioned, like between hospitals, there are some of them are competitors. They won't be happy to share all the resources. But what about in the ministry? Because ministry manage patients together, and patients sometimes you transfer and the ambulance send them to different hospitals. So what are the challenges and what are the pros and cons on doing this lifetime health record, and what are the challenges if we are trying to implement it, or maybe any queries that we are not implementing it?
I contributed a little bit from pharmacists are practice in hospital setting and private setting before. During my practice in government setting, right, I remember we get the prescription from the doctor or the information from the doctor, right? And then what pharmacists have to do is we key it again, right? So we take information from the prescribing system, bring it out, and then we key it into the prescribing system. So a lot of pharmacists are being appointed to do this administrative work. We should not be that way. I mean, pharmacists shouldn't be sitting there and then we spend hours and hours and key in all the information again. First of all, I think the system don't talk to each other, right? The API is not linked, right? It is not a universal system that I think the current system is this part is built by this person and this part is built by this person, and they don't talk to each other. So this is the ultimate things that the ministry have to look into it, right? How they going to clean the data and how they going to store the data as a whole, right? I experience I have some experience visiting pharma industry and also health industry in other countries like New Zealand and Japan and Taiwan. These three countries, when we have an official visit to their country. And what surprised me is that even though they have a private sectors and government sectors, their EMI is actually shared, right? Not all information, but important information, that essential information are being shared into the system. And if I'm a patient, I go to this clinic, I can give the right, like it's a blockchain. So I have the token given to the doctor to give them the right to access to my record. So my opinion is that a better system can be implemented, right? If our financial system can allow information sharing, right? Why not a medical health information, right? Financial information is as sensitive as healthcare information, in my opinion, right? So we have company like CTOS to able to access into our financial status, and why not we have independent system that everyone can give their rights and information access to it. And that's my opinion.
Okay, do you still have questions, Dr. Richard? Okay, thank you so much. Well, we have a question from the online participants as well. That they mentioned that it's regarding about the conversation about the Telemedicine Act and the rule that the patient should have physical examination before they can seen by telemedicine. How would that apply in the current age for patients who are in rural areas and want to seek care? And it's open to Dr. Paul or Tan Sri. Mr. Lim. Yes, Telemedicine Act.
Maybe I'll start first on the.
Sure.
I think the question is about how telehealth help us to manage patients, especially when in our training as medical doctors, right? Part of the diagnosis is we did physical examination, right? So I've been asked quite a number of times about telehealth as well as its role in the health service delivery. These questions are being asked by competitors, right? So that's why they ask these questions, or doctors who do not want to embrace digitization, right? So the question is how to manage patients if you can't touch them. I mean, these are good questions, right? How do you manage? Right. I will give that another question. In medical school, they first teach us what when you want to see a patient, history taking. History taking, how many percent comes out diagnosis? 80%. In 80% of the time, when we talk to the patient, you will have 80% chance of you coming out with the appropriate diagnosis. Now, I'm not saying that physical examination is not important. No, physical examination is very important. But telemedicine will not replace clinical practice. We cannot replace clinical practice with telehealth. We still need to see the patient and able to come to a better diagnosis. Having said that, we also can come up with an appropriate diagnosis by taking good physical examination. Taking good history taking. Remember, in clinical medicine, it's very broad. A lot of our patients that comes to us, especially in primary care level, are not complex. They come to us with skin problem. So nowadays, even in the hospital setting, skin problem, we ask the patient, can you WhatsApp me a picture? That's telehealth. Did you examine the patient? I look at the skin lesion, right? I can tell you it's psoriasis. Right. So if that's the case, you have already made the appropriate diagnosis using telehealth without touching the patient. Telehealth can be used appropriately at a very different spectrum of clinical practice. Now, it's not going to replace what we do. It's not. Very in community level, in general practice level, we have been managing patients over the phone, over WhatsApp, over Telegram already, even before that app comes into the picture. Now, that app comes into the picture is to help us streamline medication, delivery, they earn more money, things like that. But we have been using WhatsApp phones, to manage our patients. Patients have been calling us on the phone and ask, doctor, the medication that you give me that day, I have now these symptoms. Managed it from there. So they have, all right. So the idea of physical examination in clinical diagnosis still matters. We still need to touch. Remember, I mentioned earlier that human touch will not disappear. Telehealth will not replace our clinical practice. We still need human being to treat human being. Telemedicine is going to help us to streamline and make our clinical diagnosis quicker, better, and easier. If the patient is in a rural area, now I work in a rural area. Now, contrary to popular belief, rural area has got users. I mean, it's useful for rural area to use telehealth. But you forget one thing: rural areas do not have internet access. How to have telehealth? No, we have been talking about the ministry sometimes want to use telehealth in very rural area or not as the settlement. We saw in the newspaper that people have to climb trees to get internet access just to read and study. If there are no infrastructure there to help us, telehealth will not penetrate over there. So in the rural area that where I currently practice, I will still accept phone calls from patients from Penang, Tongot, Paitan. I'm sure some of you don't know what those places is. Those are the places with phone connection, but without internet connection. How to do video calls, we can't. But so we take history taking, child with diarrhea, for example, we will ask the usual questions on history taking and assess and see whether the patient needs to go to a secondary care center or tertiary care center. That's telehealth, remote care. All right. So we always thought that, oh, telehealth is very useful in the rural area. No internet, how to be useful? All right. So no, it's on the contrary side. Rural area need good infrastructure. If the rural area got good infrastructure, that place is no longer called rural area lah. All right. So rural area means real rural area. Okay. Go ahead.
Is not in effect. Okay. Telemedicine Act is not in effect. What do you call it? At present, during the pandemic, some of the private hospitals were doing telemedicine, and even in Malaysia, in India, and so forth. Even the nurses were very careful telemedicine. Now, if I were to look at some of the reports very recently from the US in this, now during the height of the pandemic, 76% of all interactions between doctors and patients in the United States was through telehealth, telemedicine. That's very high. So when it abated, it came down to about 40%. And what do you call it? And the feeling is that it will probably be along that level. But we don't know whether that is true or not. But there are issues, as mentioned. There are legal issues. There are issues relating to reimbursement, payment. In the US, that has not been clarified. Okay? Because, for example, under our law, the doctor, the hospital must keep the transaction into the medical record. For example, now, when you don't have it on your record, and patient don't have, they say, the summon of the record, that can be difficult. It is very unwittingly. It can be done. Now, the question then, when is it safe to conduct telehealth? This is being asked now, apparently, at Congress in the US. Because there are legal issues. What they're asking, whether studies could be done to advise on this part. Because legally, you must examine, you must be responsible. What is worrying in the US are data coming out which has not been validated yet. That the delays from the pandemic and to the conduct of telemedicine have resulted in delays in diagnosis of diseases, including cancer. And so that is worrying. If you look at the long time practice of telemedicine, it is through teleimaging. In other words, dermatology, radiology, pathology, telepsychiatry, no problem. Because in psychiatry, the patient has been examined and then referred to the psychiatrist. So it is easier for them to carry on. But to see a fresh new patient that has not been examined by the doctor, well, there's a problem. So there are a lot of issues that need to be verified. In Malaysia, I think the position of the medical council is that the doctor must have examined the patient adequately first, then treated the patient before you can carry on with the medicine. I think that is the current practice in Malaysia.
Thank you for the question from online. Now, we have reached about 12:40. We'll move on to the token of appreciation. Now, ladies and gentlemen, I believe this is all we have for the Q&A session. Before we end it, I would like to invite Dr. Sandeep Singh, the Vice President of the Alumni Association, up on stage to present a token of appreciation to our panelists. Thank you. I'd like to invite our panelists to move towards the edge of the stage. Where would it be? Okay. Yeah. So we can have a photo opportunity. Yeah, yeah. Okay. So this works. Okay. Ladies and gentlemen, please give another round of applause for our panelists today, Tan Sri Dato Dr. Abubakar Sulaiman, Dr. Paul Chan Hong Kit, and Mr. Lim Ken Ping. We have now concluded today's panel discussion. I hope all of us got some insight and knowledge from our esteemed panelists. Now, a quick announcement. The Malaysian Medical Association, the MMA, who is in our online audience today, would like to invite doctors online and everyone here to join them. You can obtain more details on their social media page, the Malaysian Medical Association. Now, on behalf of IMU, we would like to thank everyone for coming today, both online and here in the auditorium. There will be lunch provided outside the hall. Please help yourselves and have a great, great weekend ahead. My name is Daniel, and it's been an honor to be a host for today. Thank you. Thank you. Now, makan.